Good evening, friends. I'm Dr. Agam Vora, your secretary of one of the most powerful association, one of the most active association, one of the most academic association of India, and that is Association of Physicians of India. I welcome you to this web CME on COVID-19. Are we at the end of pandemic? Life is getting back to normal. All lockdowns are withdrawn. All masks are out. Socializing is back to normal. International travel is open. To tell you a secret, our own task force member, active brain behind COVID control, not only in my Mumbai, but also in the entire country. That's my friend, Dr. Shashank Joshi, is sitting now in USA. We are really at the end of pandemic after a long struggle. It's more than 24 months of fight after trying everything from vitamins to antibiotics, from antivirals to biologics to vaccines to even Ramdev Baba's treatment. Finally, with milder and milder variant, disease seems to be coming under control and pandemic seems to be at the end. So much I'm waiting for the announcement by WHO that yes, pandemic is over. Why is this pandemic not over yet? What does it take for a pandemic to get over? Have we conquered COVID? COVID vaccination should continue or not? Etc., are the questions that are bubbling in our minds. And there cannot be any better way to get this solved but to have a giants in the respective fields come together and give us some direction. I'm very, I'm very happy to present my close friend, that is Dr. Rahul Pandit, who's going to be the moderator of today's program. Rahul is the director of intensive care unit at Fortis, Mumbai, and is a visiting faculty at a couple of hospitals in Australia. He's a very active member of National Task Force and also the member of Maharashtra Government Task Force. He's a teacher for College of Intensive Care at Australia, also the teacher at Fellowship and Diploma courses at Critical Care Society. He has several research papers and original publications to his credit. He's a core GM site from my own institute, did his MD anesthesia from JJ Hospital, Mumbai, has several fellowships and academic honors to his credit. On my personal note, he's a close and dependable friend. In spite of his busy schedule, he has religiously spared his Sundays for public awareness program. And on the same platform, Sunday after Sunday, he solved a lot of myths that prevail in both doctors and public by and large. So with these words, I'm going to hand over this stage to Dr. Rahul Pandit. But before that, we have a president. We have our president, Dr. Shyam Sundar sir, who has joined, and I would request Dr. Shyam Sundar sir to give his blessings and formally announce the program open. Over to you, Dr. Shyam Sundar sir.
Thank you, Agam. It is a really great pleasure to. The topic is very pleasing. Is the pandemic over? And as you have said, probably yes. But still, we are getting stray cases of. Like in our city, we had 4 cases. So there are few cases hovering around. So it is a very apt time to discuss about this pandemic. And I really very appreciate this topic and announce it's open.
Thank you very much, sir. Thank you very much. Before I introduce the stalwarts in physicians, I would like our Madam Alaka Deshpande. She has been our teacher, guru at Grand Medical College and JJ Group of Hospital, and she is the Dean of the Indian College of Physicians, to actually give us some guiding words so that we can start off, Madam, and then I will introduce the rest of the 3 panelists before we begin to the core topic. Madam, over to you.
Thank you, Dr. Rahul. At the outset, let me congratulate all these young doctors. Under the leadership of Dr. Shashank, Dr. Rahul Pandit, Dr. Tiwaskar, Dr. Agam Vora have been continuously doing these educative programs for the medical fraternity over last 2 years. I don't remember any Sunday which I have not attended. Shashank and Rahul and Tiwaskar, all these people have been talking about COVID, all the various aspects about the epidemic, the management, the prevention, everything. So my congratulations to you all. Now today's topic is, are we at the end of the pandemic? At the turn of the millennium, we the medical fraternity, we knew that we are going to face a challenge from resistant bacteria and the viruses. And even before we turned the millennium, in 1981, we started the first devastating pandemic of HIV, that again was RNA virus. And then we had other epidemics like bird flu, swine flu, chikungunya, and now this COVID. This was really devastating. It has taught us many, many lessons. Now the cases are few, but always remember, I would say that this is a virus, and the virus, for its survival, because it is an obligate parasite, so for its survival, it will always try to change its genetic code. It's a genetic jugglery, RNA, DNA viruses, and therefore we will have continuously some variants, some resistant mutations, and some circulating recombinant forms. So, though the cases are becoming less and less and less, probably we are at the end of the pandemic, but I will not say that corona has gone or it is over. I'm little skeptical about it, but I would like to hear the views from all the panelists, and I'm sure something new will come. At the same time, I'll now request the panelists that with the lessons learned from this pandemic, we have to now prepare to face any other challenge which will be coming in next 2 or 3 years, because these viruses are definitely going to bother the humanity. So thank you very much, Rahul, for calling me in this gathering, and I'm eager to hear to all the panelists. Thank you very much.
Madam, thank you very much for your kind words. Really, that means a lot to all of us, and it sort of actually paves the direction in which we are going to go towards the next 40 minutes or so. So, let me introduce the three stalwart giants in the world of physicians in the country and in the world. I've got my very own elder brother, Dr. Professor Shashank Joshi. We have been together for the last 2 years, almost every Saturday, Sunday, at least minimum, and even on few of the weekdays we have been on this webinars, and we have been doing a lot of things in terms of public awareness as well as teaching. We've got a physician par excellence, Dr. Mangesh Tiwaskar, who is also the JAPI editor with the API, is a very senior physician again, and again a lot of work during the pandemic and of course before that as well. And dear friend Dr. Agam Vora, a physician, a chest physician par excellence, again absolutely brilliant mind in terms of how to manage patients in the pandemic, and not only pandemic, before that he has created a niche for himself. So with this I would like to actually start off the program first. And Shyam Sundar sir, maybe may I take the liberty to ask you the first question. I always feel, and I've spoken this before as well, that as madam said, that it's obligate parasite, the virus. It will keep on mutating itself and trying to protect itself. Do you think that it is sort of protecting itself by becoming less and less virulent and less toxic, so that it can spend more time in the host, which is us, which is human beings, and keep on infecting a lot of people around, so that we keep on moving with a mild disease and keep on sending it to another host, is that the way the virus would actually keep on staying with us for a long time to go? I would love to hear your thoughts on that, sir.
Yeah, it is, you are very right that the virus has its severity, or its spread is becoming more and severity is becoming less. But we do not know. If you remember, the first wave, or I should say in 1920, was not the most severe. Most severe wave came in 1921. The second one, which actually took the country by surprise. So, this could be a phenomena of, extinction. But I will keep my finger crossed, and and take all the precautions that are possible to fight this virus. Thank you.
Professor Joshi, your thoughts on this, and maybe if you could add on whether this mutation actually makes any uh, worse takes any worse turn towards actually having a severe disease, or maybe even more virulence than what we currently have, or we are going to see milder and milder mutations. So we really want to know that thought, because that's how whether the pandemic is going to end or not is going to depend on how the virus is going to behave now.
So, thank you, Rahul. And at the onset, I must thank the API for this initiative. And I completely echo our beloved President, Professor Shyam Sundar's thoughts, as well as Madam Deshpande's thoughts. COVID is still very much around. Many of you all may not know, but Professor Shyam Sundar is the foremost infectious disease researcher from this part of the planet. He has the highest impact factor in infectious diseases. We are very proud of you, sir, for all your achievements in infectious diseases. And therefore, your insights and wisdom is very correct that there is the virus around, a little more severe, a little less virulent. And Professor Deshpande, our teacher, was involved from the inception of the HIV pandemic. And she has seen the evolution of viruses over the last 4 decades. And she has the insights of that. And both of them have given us an insight that the battle goes on. As I talk from US, we know Bill Gates tested positive after 3 doses of vaccines. Just yesterday on Twitter, we heard that. We heard Peter Hughes, who's from Texas, who discovered the RBD vaccine, which is made in Hyderabad, also tested positive. So it is becoming a mild seasonal flu virus. That's for sure. And I agree with Professor Shyam Sundar's thoughts of swine flu, of Spanish flu. Very clearly said that the first wave was not the detrimental wave. The subsequent waves which followed were detrimental. So currently, after the original ancestral strain, we had the sinister alpha delta strains on different geographies of planet Earth. Fortunately or unfortunately, the South African or Botswana based strain wiped off delta totally, and that is a good signal. Omicron from BA1 to BA5 now is a much milder, less virulent strain. But currently, as we talk, there is a spike and a 5th wave in South Africa. And Tulio de Oliveira, who is the one who discovered the Omicron from the Stellenbosch University in South Africa, just yesterday spoke at the WHO stating that the BA5 and BA4 are still very much around. And these are strains of interest. What is the common between the 3 hovering strains from the BA2 lineage right now? The BA2 lineage has one hotspot amino acid on the spike protein, the L452. This L452 was also there in the Delta strain. So 2 things which we need to recognize. Worldwide right now, whatever India had from mid-December to mid-January or end January is very much prevailing the Omicron strain. That's number 1. Number 2, this behavior of this L452 amino acid, which basically makes the RBD loose, the receptor binding domain loose, is the critical hotspot. If that breaks through and we get a sinister variant or a recombinant, and we get a more severe virulent strain, there is a cause of concern. Is it likely to occur? The probability is very low. Because with evolution now, it is unlikely to occur. Where do we stand in India? India, we are having small cluster outbreaks in the community of a mild seasonal flu-like variant of BA2. We don't know whether we have BA4 or 5. We are having INSACOG, our Government of India agency, continuously doing genomic surveillance. So we still have mild virus, but India has had a large exposure, both to the virus and to the vaccines, with 190 crore Indians vaccinated and a very large proportion of Indians there. Currently, the hybrid immunity is in place, though there are many skeptics of this word. The second challenge which we are facing is the peculiarity of Omicron is it is a master of immune invasion, which means that it can duck natural immunity or vaccine-induced immunity, but the sting of the virus is taken away. If you have exposure and we have some degree of antibodies, the likelihood of the disease is less severe. So three things come out. Number one, protect the vulnerable. If you are severely immunocompromised, if you are organ transplant survivor, if you have severe other diseases which are underlying, you need protection. Elderly, if you are completely unvaccinated, you need protection. Protect the vulnerables. Second is that in close, crowded indoor spaces, voluntary masking is still the strongest vaccine available because it's still an airborne droplet virus. And therefore, it's still prudent to do that, at least in the closed, crowded, poorly ventilated spaces, which we see in urban
We'll
metros
come to that,
like
sir.
Mumbai.
We'll come to
And
that, sir.
the third thing, Rahul, is that we still are having a large, significant timeline between different waves. So I think currently India is sitting pretty with 3 months yet to go. But I think, as you said rightly, we will discuss that a little more. But COVID is around. WHO is not likely to declare that the pandemic is over. And we'll need to learn to live with COVID.
I think that last line of yours, sir, says it all. You've got to learn to live with COVID. Can I ask Professor Tiwaskar, sir, a very important question for us on people on ground? We are all physicians, intensivists working on ground. What is it currently that you see in your day-to-day practice, in your day-to-day patient flow, sir? Are we worried about COVID? Should we be now still going ahead and testing for patients who are coming for surgery for COVID? Or those times are gone and we really should not be bothering about it? And I would like to hear the similar views on that from Dr. Agam Vora as well, because we really need to have a clear understanding that in a day-to-day life, how much is COVID disrupting us?
Yeah. Good evening, Dr. Rahul, and thank you, Association of Physicians of India. I really wish my best wishes to our Professor Dr. Shyam Sundar, sir, our President, and Dr. Alaka Deshpande, Madam, our Dean of the Indian College of Physicians, and of course, Shashank, Agam, and Rahul, all of you, good evening. Now, you have asked a very pertinent question, and as Professor Shashank has beautifully answered it, that COVID is still around. How much it is disrupting the practice? Maybe, possibly, may not be that much disruptive as it was initially in the first and the second wave, as we have witnessed. But that should not make us complacent. That should not make us, a little bit more, I would say, casual as far as the approaches are concerned. Whether to do a regular testing, yes, it is always better to do the testing if you are suspecting, so that all the adequate necessary care can be offered not only to the patient but also to the caregiver and the society as a whole. Should they be tested before surgery? It would depend on the norm which is there usually practiced in the hospital, but I'll still encourage people to keep on testing, at least to be very sure that that the patient is positive, so that all necessary precautions can be properly followed up in the setup before surgery or before any interventions. So ideally, what the question that you want to know from me is, in the day-to-day clinical practice, how many COVID patients we are seeing? We are surely seeing much lower number of the patients. Are we testing? Yes, in a suspect case, we still are testing these patients. And should we be doing the regular tests, especially during the surgery? I am for it, because it is important to know what is the current status of the positivity, which may not be really a determining factor whether the patient should undergo a surgery or not. But at least it is always advisable to know whether the patient is positive or not as far as the COVID is concerned. Over to you, Agam.
Thank you, sir. Dr. Agam, I want to hear same questions, but I'm going to add on a question to you as well. So Professor Joshi just brought out the mask. I want you to actually highlight the need of mask from a healthcare worker's perspective. What should be the current practice? So you please answer that, as well as what Dr. Tiwaskar sort of said, that is COVID disrupting us.
Great. I think I agree to what Mangesh said about day-to-day practice, and few more points there. It is extremely important to investigate all those patients who are high-risk patients. As Shashank said, the disease is mild, but in high-risk patients of, say, organ transplant recipient, patients of your bone marrow transplant recipient, your immunocompromised patient, the disease can take serious course, and it is wiser to investigate these patients right in the beginning. So I would do that. There are rapid antigen kits also available, and that can give you answer in minutes, where you can decide about treatment. Whenever there is doubt, you can always confirm it with RT-PCR. And you know that if you start antivirals in time, it works fantastic. And then we have now many options available. We have now molnupiravir also available, and I am a believer in molnupiravir. So I feel all those high risk patients can be given this treatment right in the beginning. So second thing is about surgical fitness point of view. My fitness may not really depend on whether it is COVID positive, COVID negative, but then there are so many people involved in surgery. You have anesthetists there, you have at least five sister, two surgeons, being managed are involved in the management of that surgery, and it is putting everybody at a risk of getting infections, and their patient may not be having a high risk, but then so many people who are involved may be high risk, and it is always wiser to investigate this patient at least whenever facilities are available. And the last point that is asked to me is about importance of mask. Tuberculosis could not teach us about the value of mask. We could not ever understand the cough etiquette. And in fact, special scene at my clinic, I'm a chest physician. All parents would come and would make their children cough. Beta, jara khasi karke dikhao. And I would get that special cough, specially patients coughing for me, giving all these viruses to me as a gift. For last 3 years, I have this, I'm in clinic, and then I have this ultraviolet light, which is I've installed in my clinic. I've stopped keeping my windows closed, and I keep them open, and I have hardly used AC. For last 1.5 year, me, Mangesh, Shashank, we all bought this air purifier, and there is a gas sterilizer. We bought this in clinic. But I emphasize that this mask should be worn. 2 years ago, 3 years ago, when I made it compulsory that every patient and relatives who walks into my cabin must wear a mask. And then I realized patients would wear masks. I would give them a disposable mask, the simple 3-layer mask from my clinic. They would wear that mask, and while going, they would drop it on the way. So my entire staircase, my entire building will have this mask lying here and there. And then I changed the idea. I started giving them the reusable cloth mask. So I would autoclave those masks. They will have to wear it when they go to my clinic and leave, when they are going. And then came this COVID. With this COVID, the entire behavior changed. And I wish, pray, and bless that this must continue. Masking must continue. It is not only for COVID, it is for many other diseases where the disease spread can reduce. And I'm sure everybody has witnessed all those pollution, infection, etc. related cases of asthma exacerbations and chronic bronchitis exacerbations have really gone down in last 24 months. So I'm sure it is working well. Thank you.
Thank you, Dr. Agam. Professor Shyam Sundar sir, I have a question which is sort of pertinent to what we have been talking, but from an ID perspective, which is the high risk group of patients, apart from of course, the transplant recipients, that you are really worried about, that who may be harboring this and who may actually have a severe form of disease from a virus which is now actually becoming less and less severe? And what do you do in a bigger picture at the national level or at the state level to bring this out as an important aspect to protect them? Because this message seems to have lost somewhere, that the high risk group needs to be protected. Professor Joshi brought that out, but what do we do? How do we sort of go across with that, sir?
Well, I think the important thing is, as Agam just said, that there are many classes of people, especially the immunosuppressed, be it HIV, be it malnutrition, be it immunosuppressive drugs, even diabetes. All these people are at high risk, and they should be given all the protection, or they should take all the protection possible against this virus. And what was your second question?
How do we bring about this awareness in the general doctors as well as healthcare professions and patients themselves, that it is still very important to protect the vulnerable ones? Because that message seems to have lost somewhere, so it is not being practiced that high.
I agree with you that the message of masking is getting dwindled and getting is disappearing. But this is unfortunate. And because we are still getting cases, in every other household there will be patients or persons with high risk. So it is important that we continue to wear mask, and of course vaccine, everybody should get vaccinated. Probably it acts as a protector against the severe disease. So I think at every media, we should highlight this, that the disease is not yet over, and we should carry on the precautions that we were taking, and carry this slogan that दो गज की दूरी, mask है जरूरी. So I think this is what we should be doing.
Fantastic. दो गज की दूरी, mask है जरूरी is very, very pertinent, sir. Professor Joshi, you are in US right now, and you did give us a glimpse about the global perspective in South Africa, what is happening. But really, the information which does not trickle down is from China, and we really don't know about a lot of nations of the African continent. That how are they coping up? I mean, we've known about Europe, we've known about Northern America, a little bit about Southern America as well. But really, has Africa been hit that badly? Are we having enough information from China to say that things probably seem to be as similar in China as they are in Europe or in America? Do we have anything from the global perspective we should be alarming, sir?
So two things. As far as Africa is concerned, it is a question of equity and access. And unfortunately, only 20% of African population is vaccinated. This is a huge inequity issue. And I think we have to compliment Government of India that we have continued exporting vaccines to the African nations. We are a part of the COVAX program. And I think we need to vaccinate the world. COVID is only over when we vaccinate every person and every human on planet Earth. We are in a global village. That's number one. As Professor Shyam Sundar said, that vaccine is like an immunity booster. It prevents death and severe disease in most of the people, most of the time. There would always be individual exceptions or immune escape. That's number one. So as far as Africa is concerned, yes, it is a hotspot, but equity and access, including South Africa, only 30% of South Africa is vaccinated. So it's very important to recognize that, apart from COVID appropriate behavior. As far as China is concerned, as we talked just now, there was a first state address from North Korea by their president, stating that they discovered the first case of COVID since inception of COVID. And because of that solitary case, they have declared the whole country to be shut. Okay, this is the status of sub-countries. China has followed something called as a zero COVID policy. So has Taiwan. But the point is the West has followed a flexible approach. They have allowed economies to open up because it is a question of the livelihood versus lives. And the livelihoods took a preponderance over lives. So in China, it is presumed that the current virus of circulation is probably from BA1 to BA5. It is presumed that it is the same Omicron which is prevalent. But if you see places like Shanghai, they have gone into lockdowns. They have gone into mandatory quarantines. They have gone into mandatory lockdowns. And that is a very disruptive policy for livelihood. And therefore, though they have a large population vaccinated, probably after India, one of the largest countries in the world to be vaccinated is China. But they also have a killed vaccine and its immunogenicity potential, because the immunoadjuvant in Covaxin is a little more powerful than the Chinese killed vaccine, may not be as robust. And therefore, I think China, we need to get more data. If you see the PubMed output, Chinese researchers have published the most on planet Earth as far as COVID is concerned. As far as database generation is concerned, data transparency is concerned, I would not like to comment on it. Are you likely to get a sinister variant from China? Most unlikely. But we need to continue to be vigilant from China, from Korea, from Taiwan, from North Korea, all these places, including Hong Kong. Waves will come and go. COVID will stay. But I think Africa or China do not worry us unless and until something new crops up from there. And will it crop up? We don't know. It can crop up from anywhere. For example, we know from central of India, we did have the probable origin of a Delta strain. We know that somewhere in Africa, we had the probable origin of the Omicron strain. So virus is in evolution. I think the current thinking is that there is no major threat or concern emerging either from Africa or from China, except that we need to ensure our vaccination policies as well as our COVID appropriate behavior policies in place. And possibly with the Omicron variant being mild seasonal, the COVID zero strategy from a public health standpoint doesn't seem to be the most apt policy. And that is why governments like China need to rethink on that, because it will disrupt economy. It's unlikely such a policy will now be adapted either by state or central governments as far as India is concerned.
Thank you very much, sir. Thank you. I completely agree that we probably should not bother about other countries, but we should be very, very vigilant. So, Dr. Tiwaskar, I'm going to ask you a question, and maybe Professor Shyam Sundar sir or Dr. Agam Vora could add on to it, because I'm not sure whether all of us combined have the bandwidth about going deeper into diagnostics. I think Professor Shyam Sundar is the most expert. But is there anything new in diagnostics for COVID-19 coming up, which are considered fast? Anything new in the horizon?
Freely available in your day-to-day clinical practice, which can help you in determining probably the further course of action or even the antiviral therapy. But overall, if you ask me, I'm fairly fine with whatever the current tests and the armamentarium that we have in our tests that we are doing. Maybe
So I
probably
think
from you or Shashank or Agam, anybody can comment.
so. Are you hinting at the multiplex PCR tests which are
Correct. That's
available
what
now?
I'm
Is that
saying.
what?
Yes.
So
Because that is what.
anybody in the panel who I mean, of course, we have used it, but anybody who knows, because it almost looks like you're doing a genome sequencing in
Genome
6 hours
sequencing. That's what you know.
as opposed to 20 days, which it
20
normally
days.
takes. So,
Yes.
Professor Shyam Sundar sir, maybe you could throw some light on that, or
Yeah.
Dr. Joshi or Dr. Vora, anybody.
There has been constant improvement as far as the time is concerned. And now, as you said, the sequencing is become easy, cheaper, and in a smaller time, turnaround time. However, there are now PCRs being developed where they can be done in the field, and LAMP is one of the example, isothermal PCR. And if that becomes available at the peripheral, although it looks difficult, but it becomes simpler enough so that you just put in a drop of blood, and in half an hour you get the report. So people are at it, and they are trying to find out the ways how we can do this PCR even at the most peripheral level. So, but I don't think anything is at the moment available except that the rapid sequencing methods that we have developed.
Okay, so nothing really glorifying coming up.
So, Rahul, just a point.
Sure, sir.
Continuing what Professor Shyam Sundar said, the self-testing has become the order of the day, rapid testing. And there one advance may occur, and US FDA might approve in the next 2 weeks. So would be UK, and so would be India. And some of us are involved in that. Rahul, I don't know. But the salivary testing,
Yes.
and that is likely to see the light of the day by mid-June. Mid-June is the US FDA hearing. And we might have a salivary diagnostic kit, which might be easier than the current swab kits, which are there as a nasal swab and a throat swab. So that is one advance in this rapid space, which is there. The high genomic sequencing, Professor Shyam Sundar has already alluded to, will be very useful for rural and accessible India if it comes through the light of the day. And the third thing is India already has some point of care tests like Omishwar. They depended on the H gene deletion And we know that the S gene deletion sometimes occurred in BA2 also, so they could be little tricky. But we do have some of these point of care testing, and Tata MD has made a lot of footprint. But by the time the test became available, the virus changed its strain. So, it is like one unique thing in COVID. By the time we discover a drug or a test, the virus has gone to the next station. It is like taking a train. And by the time we identify कि this is the way we need to catch the virus, virus अगले station पे चला गया है. So this is what is happening in COVID space. But one thing is there has been a dramatic improvement in diagnostic, uplifting of the country. When we started with COVID, there were hardly any RT-PCR labs, and RT-PCR labs were only restricted to HIV, hepatitis B testing, etc. Now look at the diagnostic space in infectious disease has gone up. Also, point of care was only used for, say, glucose monitoring, HbA1c, kidney testing. So nephrologists or diabetologists were using them. Now, point of care testing has gone beyond a malaria or dengue test and has entered the space of, ID and viruses. So there has been a lot of advances. And finally, the multiplex PCR, which you are talking about, Rahul, you know that in Thane there is a center where with multiplex PCR, actually within a day you can find out the strain, but for that you need to know the molecular signature of the strain. Okay, if you don't know the molecular signature of the strain, for that you still need to do the traditional genomic sequencing, and we still need to have the sequencers. Now, of course, in Maharashtra we have Kasturba and BJ Medical College, but we have our national labs like NIV, we have INSACOG, we have the Institute of Genomics and Integrative Biology in Faridabad, and several other labs across the country which are a part of the INSACOG, where we are doing genomic surveillance. And India is not far behind in genomic surveillance as well. And we are able to decipher it, and we are on the GSAID. And now in a global village, everything is available online. So you can actually go on the GSAID website and actually find out if there is any variation occurring, any frame shift mutation occurring, any amino acid changing. And we can actually identify what's wrong with the spike, what is wrong with this. For example, in Mumbai, though we have completely 89% to 98% of the virus is Omicron now, we still have a little kappa. And every survey and genomic surveillance keeps on revealing the kappa. Delta is wiped off completely. So we need to be cognizant of all this. That's all.
Absolutely
Rahul,
correct, sir.
if you allow me,
Yes, of course,
Shashank,
of course.
what is your comment on the latest blood, the breath test which are been also tried during this period as a rapid diagnostic method, especially mass screening at the airports and all?
Shashank,
So
sir.
none of them have actually met the FDA standards, Dr. Tiwaskar. They are yet in the domain of experimentation and meeting approvals. The only test which is probably likely to come through are the lateral isothermal PCRs, which Professor Shyam Sundar were alluding, and the salivary diagnostic kits. They also have been in the anvil for the last 1.5 years, but they have to meet the quality standards of the FDA. I don't see Professor Alaka Deshpande, but she has also been involved in development of these some of similar kits in the past. So this is work in progress. But right now, I don't think we'll have a rapid breath test like we have for an H. pylori or for alcohol, for at least COVID. That's still a long way to go. It's still work in progress. But the current tests are swab, and from swab we are likely to migrate into saliva, but that is still work in progress.
Dr. Vora could keep that breath analyzer in his room when the parents asked the children to cough, so that he will have all the positive results come across. Dr. Vora, that brings me to you to a question which Dr. Joshi sort of in continuation to what he discussed. Now, is it time to write a epitaph for remdesivir, for molnupiravir, for favipiravir? Because apart from the high risk group, we are not really using these medicines to anyone. And your comment on the recently published paper about 6 versus 12 milligrams of dexamethasone in patients who were hypoxic, and they found a non-statistical improvement in the 12 milligram group. Now, India, we've always used a little higher steroid than 6. We've not been purist, really. We've either used 6 milligram BD or we've used 40 milligrams a day of methylprednisolone. So, your expert comments on this whole epitaph business for these antivirals and the steroid the conundrum about steroid keeps on going on.
If something that has helped us in the management of COVID is steroids, trust me. So it's like your age-old friends. If nothing works, steroid for sure works. People started, I was very much skeptical when the whole thing came that my COPD patients, my asthma patients, my ILD patients, I'm going to lose a lot of these patients. I was really worried about them. Luckily, those are the patients who did the best. Most of my patients of ILD who were on steroids didn't have bad COVID. They did acquire infections, but then disease somehow did not develop in them. And that probably took us to the idea that yes, there could be some beneficial effect of steroids. Second thing is all these inhalers also prevented or now they're recommended as a treatment for mild COVID. And all your asthma and COPD patients are on this combination therapy. This steroid, be it inhaled form or the systemic form, had a magical improvement when it came to COVID management. Now, COVID, as we understood now, has two behaviors. One is the initial viral behavior, and second is the second immunological behavior. But I have always been saying that to me, COVID is hardly a viral disease. To me, COVID is more like a allergy disease. It's behaving more like allergen than more like virus. It's like I always quote, it's like three children going in the garden and then they're exposed to those pollens. Somebody may have nothing, somebody may just cough, and one child may have acute exacerbation of asthma. It's the immunity in that patient that decides the disease course, so that decides the outcome. And similarly, it's more of the immune reaction than individual host which decided the outcome. So you have this, high risk patient, the elderly patient, and you were worried the most about them, had nothing. And there were so many young patients or adult patients where I, to begin with, was not so worried and they had most stormy costs. So this was the behavior. And I believe in those situations, steroid came as a big rescue. The next thing is doses of steroid. I think I have started using high doses of steroid to begin with when I was, when probably we did not know the right dose or where we went to that learning phase. But I've come to realize that minimum dose of steroid is, I think, all that we need. I think 6 to 8 milligrams of dexamethasone has done extremely well in most of my patients. And probably for last 1 year, in last 6, 7 months, so we did not have to use any drug, by and large, not required. But whenever these patients were hospitalized, whatever last I remember, I've used only this minimal dose and that too for a shorter duration. I've not continued this dose for more than 2 weeks, especially if they've not developed organizing pneumonia, if they've not developed progressive fibrosis. In most of these patients, I've stopped steroid on 10 or 14 days max. When it comes to antivirals, last couple of, in fact, last, if you ask me 1 month, I had about 6 or 7 opportunities where I've used molnupiravir. I have used it in high risk patients. I've used in healthcare professionals like you and me. Molnupiravir for sure reduces your time of infectivity. And in the sense, when I want you and me to go back to work soon, I would consider use of molnupiravir. I would consider molnupiravir may not be in the patient, but I would consider it in their relatives if they are high risk. So if your young patient may not be the candidate for treatment, but if he has a grandfather who's there in the house living together and is on regular dialysis, I would consider him for treatment because I would consider giving molnupiravir even as a prophylaxis in this group of patients. Though we don't have enough experience, but this is what I've been practicing. Thank you.
Thank you very much. I would now go, because we've got last 12 to 15 minutes remaining. I've got two important topics to sort of cover still. The long COVID, there's a publication in Lancet today, which talks about a Chinese study where they sort of went through around 1900 patients who had first wave of infection with COVID-19, and they still seem to have symptoms, predominantly the two symptoms, which was fatigue and sleep disturbance, continued till now. So I would like to start with Professor Shyam Sundar, sir, and then go on with each one of you about what's been your experience in your clinical practice about long COVID, and how do we actually get rid of this menace of long COVID, because it is really affecting some of the patients badly. Professor Sundar, sir, from you, sir.
It is not a misconception. We are seeing cases still. I mean, although we are not seeing any severe COVID now, but I have seen cases with organizing pneumonia, pulmonary fibrosis, diabetes, you know, occurring after the episode of COVID. So these are some of the issues that need to be learned and need to be, maybe that if we can have a solution about it. And I agree with Agam that steroids really have been one of the most important drug in these patients. But as far as long COVID is concerned, it is a reality, and we have to learn to live with it. And if possible, we should learn to prevent it.
So again, very important words. But how do we prevent it or make it less severe for patients who have had a disease and then after a few weeks realize that they're still suffering with the symptoms? Professor Joshi, maybe you can take it first, and then Dr. Tiwaskar sir can take it.
So I think everybody is unanimous, including Professor Shyam Sundar, that long COVID is here to stay. And whether it is a first wave, second wave, or third wave, we still are seeing patients with long COVID. New onset diabetes has clearly gone up in people with COVID who had no family history of diabetes, no risk factors of diabetes. And I'm seeing patients with uncontrolled diabetes, the only common denominator being that they had history of COVID. That's number one. Similarly, new onset heart disease, new onset fatigue, and neuromuscular symptoms. Now, the problem is it is very difficult to distinguish neuromuscular symptoms and brain fog, psychological versus neurological. And this has been a gray zone area. And also, what has happened is acute COVID is like a post-traumatic stress disorder. So, in the first and second wave, because of the isolation, because of the PPE kits, admitted patients went through a PTSD, post-traumatic stress disorder. Rahul, you and me have seen this very closely. And therefore, this was something which is a real thing. Currently, what we are seeing is that we are seeing, as Professor Shyam Sundar said, people with persistent fatigue. And often they are mistaken and misnomered as chronic fatigue syndrome or fibromyalgia. And people have given them micronutrients and so on and so forth. What is the way forward? Currently, we are looking at a cohort, and Rahul, you are also an active investigator with us. We are looking at the outcomes of long COVID in the vaccinated versus non-vaccinated group. In the first wave, we didn't have any vaccines. In the second wave, we had a small healthcare worker population which was partially or totally vaccinated, and a large proportion of the adult population, not elderly, which was not vaccinated. And in the third wave, we had a predominant population which was partially or totally vaccinated. What was the outcome of long COVID? And what I can give you a rough glimpse, global data suggests that probably vaccination or immune boosting may have an impact on the outcomes of long COVID. And this is a narrative which is being built by vaccine companies, or is this a narrative being substantiated by evidence base? Current answer is we don't know, but this is work in progress. And this is for scientists to look at. Yes, long COVID is a very tardy, tricky, and a very intractable problem which is coming up. Two features which I'm sure all of us have seen, which are very difficult to be seen as long-term consequence of COVID. One is anosmia. I have people from the first wave even now whose anosmia has not gone. And I don't have an answer. I would love to hear the answer from any of the panelists on the anosmia front. It is something which has been very, very sine qua non. In Omicron, we didn't see that anosmia to that great an extent. And second is change of taste. The change of taste, dysgeusia, which we see, again, it's a clinical marker. In the first wave and second wave, once that taste has changed, there is a small but a sustained percentage of patients who still have taste change. And अभी भी वो clinic में आके बताते हैं कि डॉक्टर साहब हमको अभी ना खाना पहले जैसा नहीं लगता है. So these are some of the unusual features. These are excellent topics for thesis and research. We have currently 4 postgraduate students, 2 have completed, 2 are yet ongoing. We will have some data in this direction, but this is something which we still need to recognize. So cardiometabolic, neuromuscular, psychological are 3 major features in the long COVID space, apart from smell and taste.
Fantastic. I think very, very insightful. We have a lot of problem with taste. We have a lot of problem with smell. And of course, this chronic fatigue syndrome mimic, which I would like to call it as a mimic, is creating a lot of trouble to many of our patients who unfortunately feel as if they are tired even before it's midday in the morning. They only work for 3-4 hours and they feel they already had a long day. Professor Tiwaskar, any thoughts on the long COVID from your side? Say anything, any unusual symptoms which your patients have presented?
Yeah.
We would love to hear from you, sir.
Yes, and Shashank has almost beautifully alluded to almost everything, and what I feel that there are a couple of more that probably I would like to elaborate, and which is one is persistence of shortness of breath, or sometimes palpitations, dizziness. There's one particular symptom that I have also seen is persistent tinnitus and earaches. Apart from that, frequency of stools going up, or sometimes occasionally episodic diarrhea, as I have seen, loss of appetite as a persistent thing. Insomnia was a big challenge which was to face. But what I would like to recommend for everybody is to try and appreciate the importance of recognizing this post-COVID care, as well as we have treated patients with COVID regularly with compassion and empathy. Probably these patients, those who are in the post-COVID phase, also need a similar intent, and they'll need a solution from the team of experts. And there has to be a protocolized management system and a monitoring system of these patients to come out with some concrete answers to all the questions and challenges that we are likely to see as an outcome of the post-COVID scenario that we are going to recover through. So we need to have a established care in your hospitals, in your clinic, in your team of the people, those who will also help you to really take care of this post-COVID scenario, as we have treated in team, along with the chest physicians, anesthesiologists, critical care specialists, endocrinologists, as a team in COVID active management. We need an active participation by a counselor, a psychologist, additionally neurologist coming up, cardiovascular physicians coming up to help us. In fact, persistent fibromyalgia like symptoms that you were alluding to or Shashank was alluding to, joint pains which has come up badly, the chronic fatigue syndrome which has come up badly. Really, we tend to take them little more lightly in the patients, and especially when it comes to elderly care, we need to be sensitized on this, and we need a team approach again, and a decided team approach, and established teamwork for this as well. What do you think?
Thank you very much, sir. I think very important to have a teamwork there. And we actually started off a post-COVID OPD in August 2020 with 6 or 7 of us different specialists doing things. We had a physician, we had a pulmonologist, we had a psychologist, we had a cardiologist, we had a rehab specialist or a physiotherapist. And it sort of helped the patients in the first wave quite significantly. But as the wave continued, we saw lesser and lesser people coming to seek the services. Maybe because now many centers probably open similar kind of services and people were able to seek them there. Uh,
Yes.
Professor Vora, sir, I have a question for you on the same lines of post-COVID syndrome. One of the important part of post-COVID management, at least in the acute or the subacute phase, has been use of these drugs to prevent fibrosis. And I still see some patients coming to me in the OPD or getting admitted as non-COVID patients, but continue to have pirfenidone or nintedanib continued, and they've never followed back to their GP or to their specialist because they were sort of prescribed these drugs. So first, I would like to really know whether we need to give these drugs, and if yes, which would be the subset of patients, and for how long, sir? I think, and then we would go back to the last few questions because we're almost covering to an hour's long of discussion already.
Anti-fibrotics. Now, I don't remember using anti-fibrotic for any tuberculous lung disease. I'm sure everybody knows that when tuberculosis heals, it heals by fibrosis, and you have that scar which remains for rest of your life. I'm sure nobody here have used anti-fibrotic there, or nobody here would think about using anti-fibrotic in situation. See, your antifibrotics are recommended for progressive fibrosis. And this, what we are talking about, what happens in COVID actually is a reparative process. So it is not a progressive disease. In some patients, this virus may trigger something that behaves like idiopathic pulmonary fibrosis or something which goes into progressive pulmonary fibrosis, and you may be justified in using antifibrotics in that small subset of patients. But I am against using, and I please urge all of you to stop using antifibrotic in this situation. And if you have put this patient, I understand there were very tough times. We were pushed against the wall. We had nothing, and we tried everything possible. with the hope to reduce lung damage. But if you put any patient on antifibrotic, I think it is the time to remove those antifibrotics because they do no good. We've got enough studies now, we've got enough understanding now saying that antifibrotics are not really indicated in these cases of COVID lung injury. And the last thing about you said only antifibrotics you asked me, right?
Yeah,
So antibiotics.
anti-fibrotic,
And
predominantly anti.
Agam, I have a point where to say that our regular COVID community-acquired pneumonias, any regular lower respiratory tract infections, they heal with fibrosis as a process of healing.
Correct,
So
correct,
we never used for
correct.
any antifibrotics for this kind of healing accelerants or something like that. So I believe that we need to take you know antifibrotics as a whole with a little care, and in the correct indication. Unless and until there is an evidence, as Agam and Shyam Sundar sir has also talked a bit about it, is this that whenever you are approaching, it's just not that uh, you are managing just a symptom of the disease, but overall as a patient's need, you need to be really very very choosy as far as your armamentarium is concerned.
Thank you very much. I'm going to have a quick rapid fire. It's going to be a very general question, but I would like to start with Professor Shyam Sundar sir again. Sir, I was just looking at a couple of tweets in the last few days, and Bill Gates' tweet is sort of making a lot of rounds right now that world needs to be prepared for a next pandemic, and we need to be prepared better. So, are we now going to see such pandemics as a more common occurrence because of various reasons? I don't even want to get into reasons, whether man-made, terrorist-made, or whatever it is. And if yes, what does a common man do? I mean, we had a fantastic childhood where we could go out, come out, play. We had a beautiful college life. We've sort of lived up to 50 at least now. But what about the next generation? I mean, how? So, just a little bit rapid fire on these thoughts. And where are we moving forward?
To tell you honestly, I don't think that this kind of a pandemic is going to repeat itself. And because of the various regions that we have already discussed, Shashank has discussed, the vaccine, the low virulent virus. I mean, these are some of the natural or man-made immune weapon that is now the population is ready. So, to my mind, I mean, we will not see, at least for COVID, we will not see such type of pandemic. Maybe some other virus will germinate from another country. That is a different issue altogether. But honestly, I don't think that this is going to happen.
But Rahul, I must
Yeah.
tell you this is a wrong question here. This question is for politicians. They know the answer. This question is for those media people, the anchors who do this program, and they seem to know all these answers here. We are poor scientists, poor clinicians here. We will never know this answer.
I think you've
Unless-
nailed it. You've nailed it. I don't need to ask this any further. Just last 2 minutes, just parting comments from you, last final words from all of you. I think Dr. Doshi is locked off. Is he there still? Dr. Tiwaskar, why don't you start?
Yeah, in fact, as Agam rightly pointed out, you, of course, this pandemic may not be repeated again and all that. But what is my probably thought on that is that we need to have preparedness for sure. One thing which has been sure shot uncovered during this pandemic time is probably the need for preparedness for the healthcare community. We get prepared for wars, our military gets trained for wars, so even in the healthcare system we need to have this preparedness taught to the healthcare professionals, to the clinicians, and we need to tell them and teach them. So I would still go a little step further, as Shashank joined back, that it could be included in the medical training curriculum as well, the preparedness for facing such kind of pandemic. Maybe possibly, if at all by bad luck, suppose some new variant comes out or something else different comes out as a pandemic challenge, really we are prepared in a better way to handle this and curtail down the menace as far as possible.
Why I brought this question out, Dr. Agam, was that in the last 20 years or so, if you see, it was screaming at us that one day we will be hit by a pandemic. We had the H1N1, we had the avian influenza, we had the MERS, we always had tuberculosis. Then we had the South Africa going through a lot of problems with Ebola. sorry, not South Africa, African continent going through sort of problem with Ebola. So we were going to be hit by an infectious disease pandemic, that's for sure. There were movies being made about it. It just looks it looks as if there's a deja vu that we were probably were finding or hoping to have it, and it's sort of here arrived at us. Anyways, on a serious note, Dr. Joshi, Professor Shyam Sundar sir, Dr. Agam Vora sir, and Dr. Tiwaskar sir, one line to sum up the whole thing. Is the pandemic ending? Probably the answer is no, it's going to stay, which is very, very clear from this. But what's the way forward? Just one or two lines from each one of you, sir.
Vigilance without panic, protect the vulnerable, and be responsible.
Thank you, sir. Professor Shyam Sundar, sir.
As we were caught unaware and our health system was exposed, as Shashank already said, that we have to be aware, we have to have infrastructure to deal with such tragedies. And as I said earlier also, that we may have another virus, another organism, another bacteria which may produce similar type of pandemic. So be prepared for the future.
Dr. Tiwaskar sir, and then Dr. Agam Vora sir.
Yeah, stick to COVID protocols, even though the pandemic is at the lower end, but follow the COVID appropriate behavior and be vigilant. That is a real good answer to Ravi.
Tuberculosis is there since time immortal. Probably even before the history. It's there even in the mummies of Egyptian bodies. Influenza is there for a number of years. I think since I was a child, I've been hearing about influenza, and we witnessed so many pandemics. So this kind of pandemics would definitely come, and it's a time to be aware of such pandemics. It is the way of, it is nature's way of probably telling you to go slow and understand. There are times like, what do we do on Sundays? We take our kids to those malls. Gone are those days when we were sitting together as a family and playing chess together, or maybe Ludo or Carom together. I think nature is giving us some signals, and we better learn from it. Thank you very much. I must thank you, for doing this program so well, Dr. Rahul. Success of any program depends on its moderation, and you moderated it so well. And icing on cake was Dr. Shyam Sundar's presence throughout, Shashank's presence right from US, and Mangesh and Madam joined, and the whole program is so successful. I must thank Aniruddha, as I call him Annie, for giving us the fantastic platform to do this program, and those thousands of delegates who have given your time, and your time means your love. It's only because of your love, it's only because of your presence that we are here and we could do this program. Thanks to everybody. Thank you, Rahul. Over to you.
Thank you very much, sir. I think you've summed it all. I don't need to add on any more words. As the secretary for API, it is your privilege to close the program, and you've done that well. So thank you very much.